Today we will be talking on the control of blood pressure, which is an important public health problem. This topic is intended for the people at large as well as for the general physician. The first is the diagnosis of hypertension. One of the most important thing for diagnosis of hypertension, how you measure the blood pressure. There are standard techniques. Patient should be in the sitting comfortable position for a certain period of time, maybe for more than 10 minutes, and then you measure the blood pressure. The cuff size should be 2/3 of the arm circumference, and then you should not drop the blood pressure too rapidly. So these are the few precautions you have to take to see the blood pressure. One of the important thing is that the white coat hypertension. So during the first or subsequent few measurements, most people have a high blood pressure in the doctor's chamber but has a normal pressure at home. Unless there is an emergency in the blood pressure recording at the first sitting, when the blood pressure may be more than say 180 millimeter of systolic, we don't initiate treatment if the blood pressure for the first time is recorded say around 150 to 160 millimeter of mercury. We can recheck the values at a certain later period and maybe after three or four serial readings, and then initiate therapy. Once we decide that we should initiate the therapy, the target to control the blood pressure, particularly systolic blood pressure, is between 120 to 130 based on the latest trial, particularly SPRINT trial in the US. So that has reduced significant reduction in cardiovascular mortality. So in order to achieve that goal, the drug combination or the drugs which has to be used has also been undergone a sea changes. At the moment, the people are thinking that the combination of dihydropyridine, calcium channel blocker, and ACE inhibitor or ARB, these two combinations possibly lowers the blood pressure most and also has a significant reduction in cardiovascular and other mortalities. And therefore, these two combinations are considered the first line therapy. The other possibilities of combining ACE inhibitor or ARB with a hydrochlorothiazide or chlorothiazide as a diuretic, or CCB, calcium channel blocker plus a diuretic, is also a possibility. But using a diuretic, particularly chlorothiazide or chlorothalidone, has got an important side effects, particularly hyponatremia and hypokalemia. If we combine chlorothalidone or hydrochlorothiazide in tropical countries, then there is a significant incidence of hyponatremia and hypokalemia. In order to avoid that, the diuretics may be minimized or can be avoided. However, these two combinations are also equally important and they have a significant reduction to mortality if the blood pressure in any case is controlled. The other thing is that there is a certain specific situations where the blood pressure control along with other comorbidities. For example, patients with a heart failure, they possibly need ACE inhibitor or ARB, they need beta blockers. For the heart failure, they may be MRA, mineralocorticoid receptor antagonist, as well as SGLT2 inhibitors. All these reduce blood pressure as well as control heart failure. Similarly, for proteinuria reduction in patients with kidney failure or hypertension with kidney disease with proteinuria, we tend to use ACE inhibitor or ARB with or without SGLT2 inhibitors. In hypertensive patient with peripheral vascular disease, we need a vasodilator therapy as a antihypertensive therapy and avoid beta blockers. In patients with a unilateral renal artery stenosis, we can use ACE inhibitor ARB to control blood pressure, but if the renal artery stenosis is bilateral, we will have to avoid this group of drugs. So there are a lot of drug combinations which are suitable in one setting but may not be suitable in other setting. So selecting a drug for one particular patient is based on whatever the primary criteria, what is his primary disease and how much you have to control. The last 2 points is that cessation of smoking, if the patient is smoking, has to be a very important factor. Vaccination and often statins are two important things. And third important thing is that salt intake. Most antihypertensive will benefit from this reduction in salt intake. We normally advise 5 grams of salt per day is good enough for maintaining life. The problem happens when some patients come with a hyponatremia. So hyponatremic patients, lot of physicians as well as the patient thinks the sodium is low, so we will have to take more salt, which is more incorrect in most of the situations. When a patient has got a hyponatremia per se, the most of the time, 90% of the time, the ideal treatment is a reduction of water intake and not increase in the salt intake. There are some medicine which can increase in the water excretion and increase salt level, but these are the drugs which should be supervised by a physician and cannot be prescribed on outpatient basis. So therefore, in most situations when the hyponatremia is a factor, irrespective of whatever reason, whether the patient is hypertensive or non-hypertensive, the treatment is still the salt restriction, but there is a more water restriction. That is most fundamental. And as I said, if the patient is also taking a hydrochlorothiazide or chlorothalidone, these group of drugs may precipitate hyponatremia or hypokalemia. These drugs should be avoided. The other final point is that most patients think once the blood pressure control is already achieved, say 120 to 130 millimeter of systolic, then they should stop the drug, which is incorrect. We have to continue the same dose of drug, which is control the blood pressure between 120 to 130 millimeter of systolic. The only when the blood pressure falls below 120 millimeter mercury, then we need a reduction in dose, not before. The second point is that a lot of patients say that our diastolic pressure is low. Say for example, in order to achieve a systolic pressure of 120 to 130, a patient comes with a say diastolic pressure of say 60 millimeter of mercury or even less than that. If that is a show, when the pulse pressure, that is this difference between systolic and diastolic pressure is high, pulse pressure is high, then they require a separate evaluation. Either they have aortic valvular disease or atherosclerotic aortic ring dilatation or some other factors are responsible for the wide pulse pressure, and they require a separate therapy. But for most of the time, when you give the antihypertensive therapy, we target the systolic blood pressure. We don't target for the diastolic blood pressure, because controlling diastolic pressure is not we don't have any drugs which can simply control or increase the diastolic pressure. So we have to look for the systolic pressure. With that systolic pressure, whatever the diastolic pressure comes is good. Only in critical situations like coronary artery perfusion, we have to keep a diastolic pressure above a certain level, because the blood flow to the coronary arteries happens mostly during diastole. So this is one of the concern, but most of the time when you control the blood pressure, systolic blood pressure, the blood pressure gets automatically controlled unless there is some abnormality in the heart or aortic valve. I think we will stop here and wish you best of luck in control of your own blood pressure.